This
उसको
conference will
बुलाएगा, ये
now
चल
be
नहीं रहा।
recorded.
Bismillahirrahmanirrahim. Distinguished faculty members, especially Professor Dr. Salim Akhtar Sahab, Professor Imran Khan Sahab Sahab, Sir Ashar Sahab, and our beloved Dr. Nasir Chaudhry Sahab. I'm extremely thankful to every one of you and my respected colleagues that you are here for this clinical meeting. I would request Dr. Hassan for recitation from Holy Quran. Thank you.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن الذين قالوا ربنا الله ثم استقاموا تتنزل عليهم الملائكة تتنزل عليهم الملائكة ألا تخافوا ولا تحزنوا وأبشروا بالجنة التي كنتم توعدون. نحن أولياؤكم في الحياة الدنيا وفي الآخرة ولكم فيها ما تشتهي أنفسكم ولكم فيها ما تشتهي أنفسكم ولكم فيها ما تدعون نزلا من غفور رحيم. صدق الله العلي العظيم وصدق رسوله النبي الكريم. In the name of Allah, the most beneficent, the most merciful. Indeed, those who said, Allah is our Lord, and remained firm upon it, upon them descend the angels, saying, do not fear nor grieve, and be happy for the paradise which you were promised. We are your friends in the life of this world and in the hereafter. In it for you is all that you may wish for, and in it for you is all what you may ask for. From the hospitality of the oft forgiving, most merciful. وَمَا عَلَيْنَا إِلَّا الْبَلَاغُ.
Thank you, Dr. Hassan, for such a beautiful presentation and verses from Holy Quran. I would request Dr. Usman Hamza for a
Thank you, Dr. Irfan. I welcome you all from Department of Ophthalmology, Jinnah Hospital, Lahore. I am thankful to my mentor, my teacher, Professor Salim Akhtar, Professor Imran Akram Sahab, Professor Arshad, and all senior and junior faculty members, and my all students and my ward colleagues. First of all, I am very thankful to oversee the Hospital for giving us this academic activity to and I'm also thankful to Professor Zainab Abbas. He will give a lecture of the principle of regenerative medicine. He is professor from Punjab University. For further proceeding, I will invite Professor Nasir Chaudhary and proceed for the session. Thank you.
ये चाहिए होगा ये चाहिए होगा नहीं इसकी तो नहीं जरूरत है Bismillahirrahmanirrahim. This is such a delight to be here with elegance and elite of medical profession. I would like to extend my deep gratitude to Honorable and worthy Professor Dr. Ramadaju. Unfortunately, he had to leave to attend the funeral of his uncle early this morning. And then we have an excellent teacher, a great surgeon, head of I Unit 2, Professor Dr. Uzma Hamza, and an excellent and outstanding associate professor who can undermine the administrative skill of this young associate professor, Professor Kashif Jahangir. Our worthy teachers, Professor Imran Akram Sahab, Professor Salim Saab, Mia Shah, Mia Mukhtar Saab, and then we have Khaja Khalid Sharif Saab, Professor Ahmed Saab, and other prestigious gatherings from different institutions of Lahore. OSP Lahore is one of the oldest and largest society of medical fraternity, and this has been nurtured by the sweat and blood of our worthy teachers. The ophthalmic fraternity will ever remain in debt to our worthy teachers for taking the historical breakthrough, indeed a great initiative of starting this clinical meeting. Because currently we are living in the era of artificial intelligence, and there are so many resources available through social media, but the importance and clinical significance of this meeting always stands out because it promotes and it increases the integrated patient-centered approach through interprofessional communication and interdisciplinary approaches, like we have guest lectures in our clinical meetings. So these clinical meetings and professional societies are believed to play a significant role in benevolence and professional development of its members. And OSP, through the utmost dedication and compassion of our worthy teachers, OSP Lahore has turned into a robust organization, and we can see we have more than 17 branches across the country, which are representing Pakistan in the best possible way across the globe. And OSP Lahore has uplifted research culture in the country through the innovation of OREEF, that is the Ophthalmic Research and Education Forum, then high impact journal, PDO, and then free research paper. We have routinely conducted medical education sessions and leadership development program for our young faculty and continuous medical education. We have quiz, wet lab, stimulations, and live surgery time to time arranged through the platform of OSP for the young faculty, people working in the remote periphery, and even the consultants working across the different tertiary care and primary centers. These clinical meetings basically provide a great platform and avenue that promotes patient care and that promotes basically starts off and fosters that academic environment uh, to promote a workplace place assessment, formative assessment, you can say, and by presenting the clinical scenarios, clinical presentation in these meetings, we can refine our clinical and surgical approaches because large volume of opinion of our worthy consultants were available under one roof. And many times, as highlighted time to time by Professor Ibrahim Saab, many of our students they struggle by passing through the final clinical examination. So this exercise, basically, you can say mark a clinical meeting provides you to refine your weakness, and then you can improve these weaknesses on the basis of feedback generated through clinical meeting in the final summative assessment. OSPLOT has a tradition of awarding certificates and souvenirs to the first, second, and third presenters. So, for this clinical meeting, I would like to request Professor Salim Akhtar Saab, Professor Mia Arshad Saab, and Professor Amar Saab in place of Dr. Sara. They will serve as and play the role of judge to grade the presentations of today's clinical meeting. Now I would like to request Professor Dr. Fark Ahmed to carry on the further scientific session of this clinical meeting. Thank you.
Thank you, Sir Nasir. And today's our first speaker is Dr. Salman Nasir. He would be talking about bilateral improvement in age-related macular degeneration following unilateral aflibercept injection. Dr. Salman.
Thank you. Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Salman Nasir, a third-year resident at Ophthalmology Unit 1, Jinnah Hospital, Lahore, under the kind supervisorship of Professor Dr. Mohammad Hamad Ayub. First of all, I would like to present my sincere gratitude to the OSP and to my department for providing me with this opportunity. I will be presenting a case on a very rare and interesting topic related to the use of anti-VEGF agents. The patient is a 62-year-old male, married and retired teacher by profession. He is a resident of Lahore. Patient is a non-smoker and non-alcoholic, and he has no known drug allergy. The patient presented to the OPD with a complaint of decrease in central vision with metamorphopsia for the past 2 months. The decrease in vision was gradual in onset, and it did not have any aggravating or relieving factors. The decrease in vision involved both eyes, and it was not associated with any pain, photophobia, flashes, or floaters. The patient's systemic history was unremarkable for any comorbid such as diabetes, hypertension, ischemic heart disease, or cerebrovascular disease. Similarly, the ocular history was also insignificant for any previous ocular medication, ocular or periocular injection, ocular laser, ocular trauma. The patient was using glasses for near vision. These are the examination findings of the patient. As you can see, the decrease in visual acuity was in both eyes. The IOP was within normal range. Pupillary examination in both eyes was unremarkable. Extraocular movements were full in both eyes. Similarly, anterior segment examination was also unremarkable. However, in the posterior segment examination, we noted altered macular reflex and drusen in both eyes. These are the fundus pictures of the patient's right and left eye. As you can see, there is altered macular reflex as well as drusen in the macular region. These pictures show the OCT of the patient's right and left eye, which shows subretinal fluid, the subfoveal fluid basically, and also a minor PED in the right eye as well. So, on the basis of clinical investigations and examination, a diagnosis of bilateral neovascular AMD was made. The patient was advised bilateral intravitreal aflibercept. Due to financial constraints, the patient opted for the treatment of right eye only. Following aseptic techniques, 0.2 mg of aflibercept was injected in the right eye only. No immediate complication was observed, and the follow-up was set at 4 weeks. Now this is where the things get interesting. At 4 weeks follow-up, the visual acuity was noted to be 6.9 in the right eye and 6.12 in the left eye, and reduction of central scotomas bilaterally. Similarly, on the repeat OCT scan, there was significant absorption of subretinal fluid bilaterally. Please keep in mind that we have injected only the right eye of the patient, and we are seeing improvement in both eyes. At 12 weeks follow-up, the vision further improved to 6.6 bilaterally, and there was complete absorption of subfoveal fluid that was also seen bilaterally. No systemic side effects were observed in the patient. These are the pre and post-treatment OCT of the patient at 4 weeks follow-up, which shows significant improvement in resolution of the subfoveal fluid. This slide shows the section of OCT at different levels. And this graph shows the improvement in visual acuity over time in both eyes. The green line, as we can see, shows the improvement in visual acuity in the right eye, and the dotted red line shows improvement in vision in the left eye, which was uninjected. At 12 weeks follow, both eyes had a visual acuity of 6.6. So this brings us to the important discussion of this case presentation, which discusses the rare phenomena observed with the use of anti-VEGF agents, the so-called fellow eye effect, in which anti-VEGF given in one eye appear to influence the contralateral untreated eye. It has been previously documented in literature, but mainly with bevacizumab and ranibizumab. These are some of the references I have quoted, which show the previous fellow eye effect with use of different anti-VEGF agents. The anti-VEGF agents work by inhibiting the vascular endothelial growth factor, which plays an important role in both physiologic and pathologic angiogenesis and vascular permeability. Bevacizumab and aflibercept contain an Fc fragment that binds the endothelial cell receptor and undergoes the FcRn-mediated recycling, which prolongs its half-life. Notably, the half-life of bevacizumab, the systemic half-life of bevacizumab is 10 days, and aflibercept has a half-life of 6 days. This interaction, which I have previously described, also helps and facilitates the translocation of anti-VEGF agents across the blood-retina barrier. Ranibizumab, on the other hand, is a Fab fragment and has a markedly shorter intrinsic systemic half-life of only 2 hours. So it is cleared more rapidly from the systemic circulation. This slide shows the interaction of various anti-VEGF agents with the receptors. This is a 2017 study which compares the pharmacokinetic and pharmacodynamic properties of the 3 most commonly used intravitreal agents, namely aflibercept, bevacizumab, and ranibizumab. This study concluded that bevacizumab and aflibercept demonstrate a greater systemic exposure and prolonged effect by remaining in the systemic circulation for a longer period. And there was a reduction in free plasma VEGF levels more with bevacizumab and aflibercept as compared to ranibizumab. And similarly, the study found out that the systemic ranibizumab concentration remained below its minimum inhibitory concentrations, whereas those of bevacizumab and aflibercept remained well above the minimum inhibitory concentration in the circulation. This is another study which compares the risk of systemic adverse effects with the use of aflibercept, ranibizumab, and bevacizumab in clinical practice. This study concluded that the side effects resulting from the use of anti-VEGF are due to the systemic absorption of these agents, and there was an increased risk of cardiovascular, arterial thromboembolic, renal, GI adverse effects, and wound healing complications. And the study found no difference in the risk of adverse events with all three main anti-VEGF agents. This diagram illustrates the absorption of anti-VEGF from the vitreous cavity into the systemic circulation, and acting on the vessel endothelium, it brings about side effects in various organs of the body. This is a novel study which was done on the study of drug concentration in the fellow eye after unilateral anti-VEGF agent injection. Although minimal, this study found out that there was trace amounts of anti-VEGF in the fellow eye as compared to the injected eye. So this brings us to the conclusion of the case presentation. We know that anti-VEGF are used on a large scale in today's clinical world. These have an overall very good safety profile and are safe in a majority of patients. However, there are known systemic side effects of these agents as well, which I have previously described. And with the use of all three commonly available anti-VEGF agents, there is no difference in the systemic side effects. So this raises some important questions that either should we wait and then inject the fellow eye to observe for the systemic absorption and the effect on the contralateral eye, and should there be a protocol for monitoring of the systemic side effects of these drugs in patients, in general population as well as high risk patients. So it puts a great emphasis on further research on the properties of anti-VEGF agents to improve outcome for both the patients and the physicians as well. So that's all for my presentation. Thank you so much.
Thank you. Thank you. ये मुझे सर है
कौन से करोगी? This is the point. ये वाला point है, ठीक है। यहाँ से पकड़ो, यहाँ से point out करना होगा।
Thank you, sir. And now I would like to request our next speaker, Dr. Samrit Saeed. She would be giving us, presenting a case presentation on steroid responding uveitis.
Bismillahirrahmanirrahim. Assalamualaikum. I'm Dr. Samrit Saeed, President of Ophthalmologist, and I'm going to identify supervision of Dr. Usma Hamza, who is the head of department of our affiliate. Today, I am presenting a very unique case of 45 years old female who is a housewife, married and has two children and residing in Lahore. She presented to us with decrease in vision, pain and redness in her right eye for last 2 minutes. And worsening of vision and ocular pain for last 7 days. She was in real state of health when 2 months back she experienced mild decrease in vision in her right eye and was associated with pain, photophobia and redness. However, there was no ocular discharge, doctors and flashes of light or diurnal variability. She consulted over multiple local doctors and who diagnosed her as having anti-uveitis, and she was on topical steroids. After the first week of this therapy, her intraocular pressure reduced. So they advised her anti-glaucoma medication also. Now she presented to us with complaint of worse vision and ocular pain. She also gave a history of multiple small joint pain that was intermittent and associated with stiffness and swelling. She was using presbyopic glasses for the last 3 years and the rest of the ocular history was unremarkable. There was no significant past medical history or her family history was unremarkable. She was non-addict, non-allergic and belongs to middle class family with no pets at home and her travel history was unremarkable. So we began with general physical examination. A middle-aged female sitting comfortably on chair, well oriented in time, place and person with normal vitals. Moving on to ocular examination, her left eye was unremarkable, whereas in right eye, the best rated visual acuity was 624 for distance and N10 for near vision with glasses. Her color vision was normal, pupil was sluggishly reactive, and extraocular movement was good. On critical examination of her right eye, the lid and the adnexa were unremarkable. There was a diffuse conjunctival injection, and cornea showed diffuse epithelial and stromal edema with non-dwelling macular fine cavities. The anterior chamber was deep with plus tube cells and flares. The pupil was sluggishly reactive, and there were no posterior sinuses, and lens was clear. The intraocular pressure in her right eye was 48 mm of mercury and it was 16 mm of mercury in her left eye. On subsequent visits, we performed colonoscopy with the help of 5% hypertonic saline to overcome the body edema, and grade 3 structures were visible in all quadrants, with no signs of secondary angle glaucoma. Moving on to posterior segment examination, the cup to disc ratio ratio was 0.7 to zero point 0.8 and rest was unremarkable. So, depending on the clinical examination and presenting complaint, we perform a battery of systemic investigations in which the C-reactive protein was slightly raised and DNA profile was positive, and rest of them are normal. As per Dr. This ratio was 0.7 to zero point 0.8, so we perform optical coherence tomography of optic nerve head and retinal nerve fiber layer along with central corneal thickness. These are the reports of that patient. This is the color picture of optical coherence tomography of both eyes with good thickness time. And here we can see the retinal fiber layer giving in clear quadrants of right eye. Her central corneal thickness was 504 microns and 508 microns in left eye. So based on her clinical findings at the first presentation in our setup, we switched topical steroid from prednisone to chlormethadone. We gave her intravenous 200 cc injection mannitol over 20 minutes and added oral acetazolamide along with potassium supplements. As she was already on triple antiglutama, so we added cyclopentadate eye drops. After all these therapies, her intraocular pressure reduced to 28 millimeter of mercury. At the same time, we liaised on with the rheumatologist and studied immunomodulator therapy with oral methotrexate once a week and low-dose oral steroids, channel kinase inhibitors along with folic acid and calcium. Over 3 weeks, her uveitis responded to the treatment and AC activity reduced to +1 to +2, but the intraocular pressure was still uncontrolled and it was in the range of 30 millimeter of mercury. So in the treatment planning of this patient, our aim was to work out the best possible way to reduce intraocular pressure and inflammation. But the problem is that we have to keep in mind that any intervention we will do that is steroid after the surgery may affect our ability to control the intraocular pressure as she was a steroid responder. So keeping in mind the young patient as a significant structural damage on optical coherence tomography and uncontrolled intraocular pressure despite the maximum medical therapy, so we decided we will go for surgical intervention. We reviewed multiple options like precision surgery, glaucoma drainage devices, minimal invasive glaucoma surgery, cyclophotocoagulation along with pros and cons. Our first consideration was trabeculectomy with MMC, that is a gold standard glaucoma surgery. But the main issue was there is a high risk of failure in presence of anterior chamber inflammation. And we also have to provide post-operative intensive care with steroids to avoid blood failure. So keeping this in mind, we move towards the glaucoma drainage devices. The biggest advantage of these devices is that they are effective even in presence of anterior chamber inflammation and they can reduce the intraocular pressure that is comparable with the trabeculectomy. So we discussed all these options with the patient along with risk and benefit, and we decided we will go for glaucoma drainage devices, specifically glaucoma valve implantation under general anesthesia. So these are the pictures that show how we perform glaucoma valve implantation by short span and short rhythm technique. There is a small span, 3 millimeters behind the nipple, and the span is secured with the sclera with the help of non-absorbable acetone. And the short rhythm is created with the help of 23 gauge needles from here to here, and the two into the 7. And you will withdraw here and 23 needles is added into the anterior chamber, and the tube is moved into the anterior chamber and slab was closed with the help of non-absorbable nylon 10-0. This is the final picture of this patient. Here we can see around 2-3 meters are being implanted in the anterior chamber of this patient without lens and corneal touch. We advise topical antibiotics and chloromethadone along with nephapenic after the surgery. On first follow-up, the intraocular pressure was 8 millimeter of mercury, cornea was clear, and AC activity was +1 cell. On 6-month follow-up of this patient, her intraocular pressure was stable and it was between 10 to 12 millimeter of mercury, VN was Now, ladies and gentlemen, I would like to present a paper that was published in Circle of Ophthalmology that compare Ahmad glaucoma well implantation with trabeculectomy. In this paper, it was shown that the success rate of trabeculectomy in uveitic glaucoma was 66.7%, whereas it is 100% in Ahmad glaucoma well implantation. This is another study that compares three treatment modalities, that are Ahmad glaucoma well implantation, trabeculectomy, and cyclophotocoagulation. This paper reveals that the Ahmad glaucoma well implantation can cause less inflammation as compared to other two techniques in inflammatory glaucoma. And in the last, these are the current guidelines from the American Academy that mentioned that glaucoma training devices are preferred first-line surgery in uveitic glaucoma, especially in cases with active inflammation. So in the end, I would like to end my talk by recapping that steroid-induced glaucoma in presence of uveitis poses a significant treatment challenge. So we can use oral and mild topical steroid along with immunomodulators to control the uveitis. And glaucoma drainage devices prove to be very effective in such cases to control intraocular pressure. That's all. Thank you for your kind listening. Any questions from you? सर ट्रेबेक्टमी में बेसिकली हम लोग जो है एक ब्लड क्रिएट करते हैं, ठीक है, और आइलेक्टमी करके हम लोग एक पैसेज बना देते हैं फॉर एक्वस ड्रेनेज इनटू द सबक्यूरॉन स्पेस। तो जो हमारे पास है ग्लूकोमा बल, उसमें हम जो प्लेट है उसमें एक बल्ब होता है, वो हम लोग एक ट्यूब जो होती है वो एंटीरियर चेंबर में डालते हैं, उसके जरिए फिर एक्वस होता है वो ड्रेन होता है सबक्यूरॉन स्पेस। इनका सब कंजक्टाइवल चल रहा है।
Now, our next presenter, Dr. Sara Farooq, should be presenting a V pattern exotropia, transformative strabismus surgery.
Bismillahirrahmanirrahim. Assalamualaikum. I am Dr. Sarah, second year resident doing FCPS training from Jinnah under the guidance and supervision of Dr. Muhammad Amal. So today I am going to discuss about the transformative strabismus correction. So what do you think? What are the reasons for strabismus correction? Cosmetic is the first reason for which people do cosmetic strabismus surgery. Second one is to preserve the hair. Third one, prevention of amblyopia. And next one is about health issues like today with the low confidence, irritability, and social isolation. What next? Any other indications? Anyone want to add up for the audience? So, sorry, Mohammed, on behalf of already told. So, this is the curiosity, or you can say creative perception or depth perception of the object. तो क्या आपने कभी कोई थ्री मूवी देखी है उसको देखने के बाद आपने उसको किस तरह से एंजॉय किया था वो आप सोचे अपने जहन में लाएं और एक ऐसे पेशेंट को सोचे जिसने कभी थ्री इफेक्ट देखा ही नहीं है उसके स्ट्रेटजिक की वजह से कभी स्टीरियोसिस डेवलप नहीं हुई तो ये हमारी रिस्पॉन्सिबिलिटी है कि हम अर्ली करेक्शन करके पेशेंट की स्टीरियोसिस को बचाएं विद इन अर्ली एज ऑफ लाइफ So, keeping this point in mind, now I want to discuss a case of 20-year-old boy, unmarried, resident of our who presented to us on 26th of April 2024, which is presenting a pain of upward radiation of mind since childhood. So, he was having upward radiation since childhood. Right eye was the dominant one. It was associated with headache, strain, and difficulty to focus on one target object. He was also having lack of confidence and social isolation. So, after the ocular history, we need to classic correction of myopia. Rest of the ocular history was unremarkable. His systemic history was unremarkable. So, social domain status he belongs from middle class family and he was a college student. So, these are the words of the patient which he has to say about his complaint. And this video is recorded after the surgery by taking the consent of the patient. He is saying that उसको अलग-अलग कामों से अलग-अलग जगह पे फोकस होता था और सर में दर्द रहता था चिड़चिड़ापन रहता था और ये इसकी मेन प्रेजेंटेशन ऑफ पेन थी So we did the examination of the patient. His visual acuity was 612 in both eyes with best corrected visual acuity 6 with minus 1 dioptric focal length. His color vision was absolutely normal. On the doing the extraocular movement, he was having brief pattern exotropia with bilateral inferior oblique overreaction as you can see in this picture. On the extravertebral, he was having the left inferior oblique overreaction should go bilateral and last session with superior transposition 9 mm. Left memorization 5 mm and bilateral to POD by acne Boston. In right hand, they were muscles and in the left hand, they were trees. This is the pre-operative and post-operative comparison of the pictures of patient. These one are after 3 months. So this is review after 1 year. So this is the most important video, which is review after 1 year. These things that एक का रेजोल्यूशन करवाया था उसको ऑपरेशन करवाने का बहुत फायदा हुआ और उसके साथ फोकसिंग हुआ है रिडक्ट पर एक्टिविटी हुई है और उसका कॉन्फिडेंस डेवलप हुआ है साथ ही पॉइंट बताता है कि आपको देखकर पहले से कभी इस तरह नहीं देगा इसका मतलब ये कि रिडक्ट पर एक्टिविटी नहीं करी उसने आप इस तरह देखा जैसे एक फ्लैग लग रही थी लेकिन अब उसकी पीठ पर एक्टिविटी डेवलप हुई आपको पता नहीं है सो दिस इज अ वेरी पॉजिटिव इफेक्ट ऑफ सर्जरी. So here are some reference articles which are showing the significance of stereotypes. Another article practice technique and movement of stereotypes following successful surgical test on childhood treatment. So most important factor is the orthoscopia for achieving the stereotypes. Another article for use of stereotypes. So the pattern goal of the pattern is not just aligning but to align in time. In time, this is the most important one. We have to achieve this alignment within 30 days to achieve the POC or to restore it. So, what is messages? There is a huge psychosocial impact of traditional on the personality and confidence of patients. And early management can be helpful for resolving the anxiety and transforming the lives of patients. So this is the ideal age group to be considered for early management. So I am ending my presentation with timely surgery that not just transforms the appearance of person, but the person himself. Thank you. Sir, step by step. Sir, video can start again. Sir, क्यों check करते हैं? जी. But you have emergency check करते हैं. So either you are aiming to do the fusion or you are just trying to help fusion. एक 15 दिन बन चुकी है लेकिन किसी वजह से स्टेटस हो गया था उसकी अपनी प्रोसीजर में देख सो तो दूसरी चीज लेजिस्लेशन स्टूडेंट बनी है लेकिन ये लेजिस्लेशन होता है तो उसमें आप करेंगे उसकी क्यों करना है जी इसमें आपको कैसे पता चलेगा कि सर उसकी जब इमरजेंसी थी तो उसके पार्ट में जो है कन्वर्ट किया था इसको मतलब ये कि उसके लिए तो कुछ कंपोनेंट है दूसरा सर दूसरा जो कौन सी करना है बेस्ड ऑन जी जी सो बहुत आसान क्वेश्चन है कि आपकी अपनी प्रोसीजर थी जी या आपको स्वेट के सेशन में क्योंकि इसकी लाइफ जी जी सर क्योंकि बात है कि जो कोऑपरेशन था सर due to diplopia unable to focus on one target object. Hmm. जी वो सप्रेस कर देते नहीं जी थैंक यू
Now, the next presenter is Dr. Chandra Abbas. Topic is intriguing case of posterior segment pathology. Assalamualaikum. I'm Dr. Chandra Abbas, second year postgraduate president of Psychology at IIM Institute of Hospital, under the guidance of Professor Mohammed Hamad.
I will discuss this very intriguing case of serious pathology. Unfortunately, a senior male lawyer by profession and president for all presented in our OPD displaying a disturbed vision in white eye for 1 month. It was gradual in onset with no association with pain, photophobia, glare, floated from photoxia. There were no relieving or aggravating factors. His past ocular history was unremarkable with no history of anti-ocular medicine, periocular or ocular injection, ocular layer trauma, or glasses. His systemic history was also unremarkable with no history of tuberculosis, autoimmunity, arthritis, any diabetes, hypertension, or any other disease. In his personal history, he is not using any recreational drugs and there is no known drug therapy. Coming on to examination, our patient was widely stable, well oriented in time and place. Vision in the right eye was 6 by 18, and there was no improvement on refraction. Vision in the left eye was 6 by 6. Pressure of both eye was normal. RAP was negative. However, on answer there was metamorphopsia in the right eye. The rest of the examination of the left eye was unremarkable. The TS segment of the right eye was also normal. However, in the CS segment, there was a vitreous activity of +2 and a subretinal lesion was noted. As you can see in this Spiders photograph, there is a 3 diameter lesion in infratemporal region, that is 2.5 diameter from the optic disc and 1.5 diameter from the fovea. There is no overlying pigmentation and it is giving a yellow and orange hue, and it is surrounded with a subretinal fluid that is encroaching into the mirror fovea, and the macula is off. However, there are no hemorrhages, bruises, or any choroidal folds. This is a picture of the same lesion in a red 3 filter. So, in order to further investigate this case, we ordered a CT scan, an OCD, and a fundus fluorescence angiography. On these scans, there is a dome-shaped lesion with a smooth surface and with low internal refractivity. There is no further excavation, and there is a mild elevation of the retina around the lesion. There is no sign of scleral thickening or descent. As you can see, the A white upper corner picture. In this A mode, there is no extra peak within the lesion, which may represent a dual inner circulation. So, coming on to the OCD, there was an elevation of retina with disintegration of internal retinal layers. There was also a subretinal fluid. There was also elevation and displacement of RPE by a hyporeflective choroidal lesion. Moving on to the FFA, there was early hyperfluorescence that increased in the late period with cooling and staining. However, there was no double or dual inner circulation noted. We also ordered some systemic investigation to find any systemic associations. In turn, the ESR, CFE, and serum ACE level were raised, and TB load was positive. On ultrasound abdomen and pelvis, there was also white, mild, and diffusion. We also ordered NMR of vein and orbit via the order. We found a hypotensive lesion in T2 for the posterior segment of the right eye. And in T1, with cutoff, there was a controlled enhancement of the lesion with no extraocular extension. So, based on our clinical examination and our investigation, we shortlisted our differential diagnosis with the highest suspicion on inverted granuloma because the patient had extraocular inflammation and an 80-fold positive, and there was a wide pleural effusion. So, the most evident in this case was to look at a choroidal melanoma, a next differential. So, the choroidal melanoma has a low internal refractivity on B10, similar to RPs. However, it also has a haloing effect on a B scan, which was not found in our case, and a melanoma case, as in this picture, you can see the visual inner circulation as found in so, and moving on to our next differential was choroidal hemangioma, which has a high internal reflectivity on B scan, but our lesion has a low internal reflectivity, and so it is also ruled out. Our next feature was choroidal osteoma, which is more common in females and has is a calcified lesion with a high internal reflectivity on B scan. But our lesion has a low internal reflectivity and our tissue was just next question is choroidal metastasis that is mostly a multifocal and bilateral, but our lesion was unilateral in where we find the patient has no history of any malignancy or any clinical examination. This patient is also various has a different clinical picture being a white granuloma and it is more common in children and has also a moderate to high internal activity which was opposite to our case, which was also ruled out. Finally, the posterior sacroiliitis that is mostly associated with pain and has a T sign on B scan or posterior spiral thickening. As you can see in this picture, which was not found in our case, it was also ruled out. So we made a final diagnosis of tuberculous granuloma and we started our management accordingly. So we took the multidisciplinary approach and referred the patient to pulmonologist. He ordered a chest X-ray that was normal. So he further ordered a CT chest with control where he found a mild pleural effusion. He advised the patient an ultrasound cardiac effusion, drainage of the pleural effusion, but the patient was not compliant and refused to do so. So we started a patient with anti-tubercular therapy, 4 tablets of myelin before breakfast and tablet Vita 650 mg in the evening. We started the patient with 30 milligrams of systemic prednisolone to settle down the inflammation after consultation with pulmonologist. And we asked the patient to keep commenting forward. So after one follow-up, the visual acuity was 6/9 with drastic improvement and the size of the lesion and separation were also reduced. Patient was taking ATD according to dosage and we advised the patient to repeat the scan. And inshallah, we are on the follow-up of the patient, keep the follow-up accordingly. So finally, to summarize this case, the most challenging thing in this patient was to rule out choroidal melanoma, and the same patient visited another tertiary hospital and was diagnosed with choroidal melanoma and was advised a white medication. But as we know, that many of the subchoroidal lesions have approximately similar clinical signs, and the prevalence of TB is high in our community, and so sharing the prevalence of tuberculous granuloma. We must think of differential diagnosis other than choroidal melanoma, even if we are suspecting choroidal melanoma. So, a thorough clinical examination, wide investigation, teamwork, and a multidisciplinary approach can help us reach the right diagnosis and can change the fate of patients. In that, I want to give special thanks to my faculty, our head of department, and our assistant professor, Dr. Mohammed Saad, and our senior registrar, Dr. Major Lodge. Without whom I was unable to take this case. Thank you so much. And thank you all for all the patient listening. Any questions and remarks are welcome. We continued for 1 month after we tapered.
ये आपको क्या नजर आ रहा है? Rai has been taken out, है ना? In equation whatsoever has been done. यार इसको चलाओ जरा। आपके ख्याल में इसकी किस एज में इनिक्लिएशन हुई है? हैं जी? तो मैं थोड़ा पूछ रहा हूँ। ये हाँ बेटा देखो, असल में व्हाट आई एम ट्राइंग टू एम्फसाइज, इसकी वाकई 1 साल से भी कम उम्र में इनिक्लिएशन हुई, इम्प्लांट नहीं पड़ा। व्हाट आई एम ट्राइंग टू एम्फसाइज इज कि प्रेजेंस ऑफ योर आई कितनी इंपॉर्टेंट है। एज द आई ग्रोज द ऑर्बिट ग्रोज, और उसके साथ साथ अब ये देखें मैक्सिला, मैक्सिला की ग्रोथ भी हमारी आई के साथ है। अब इसकी आंख उन्होंने निकाल दी, ठीक है, इसका ऑर्बिट जो है ये इतना सा है, ये ऑर्बिट यहाँ से लेके यहाँ तक है और ये ऑर्बिट यहाँ से लेके यहाँ तक है, ठीक है ना, छोटा है, लेकिन इसका मैक्सिला डेवलप नहीं हुआ। और उसकी वजह से आप एक चीज नोट करें, यू सी द फेशियल एसिमेट्री, ये पूरे का पूरा फेस डेवलप नहीं हुआ इस तरफ से, और वो फेस ग्रो करके इस तरह शक्ल बन गई है। So you can imagine that just not putting in an implant is all important for that. ये मैं ये emphasize करना चाह रहा हूँ कि जब भी आप इनिक्लिएशन करें छोटी एज में, always put in an implant. और फिर उसमें भी कोशिश ये करें कि try to put in an implant जिसको आप वक्त के साथ बड़ा कर सकते हैं, ठीक है ना, आप वक्त के साथ बड़ा कर सकते हैं। 6 साल की उम्र तक उसको बड़ा करना होता है, और उसके साथ साथ ऑर्बिट भी ग्रो करता है, फेस भी ग्रो करता है। दिस इज व्हाट इट इज। लेकिन इंपॉर्टेंट ये चीज है, ये देख रहे हैं आप, दिस साइड ऑफ द फेस हैज नॉट ग्रोन, पूरे का पूरा फेस सिमेट्रिकल हो गया। तो ये मैंने मैसेज देना था आपको। थैंक यू वेरी मच। चल भाई, ये भी मैं सामने नहीं जाता फिक्स।
Dr. Allama, the distinguished educational and researcher at the Institute of Molecular Biology and Molecular Science, University of John. He has earned his PhD in immunology from the University of London, where he developed antigen targeting strategies for cancer vaccine development. With his specialization in cellular and molecular dynamics, his current research explores innovative regenerative approaches, particularly the use of radionuclides, stem cell emission media, and feather-rich plasma for treating mastitis, diabetic wounds, and skin regeneration. Professor Raj has led several national and international funded research projects, contributed over 1,400 citations to scientific literature, and is an active educator and academic leader, teaching advanced courses in immunology and stem cell biology. He also serves on multiple editorial boards and academic committees, reflecting his commitment to advancing both science and education in Pakistan and beyond. Today, he's here with us and he will give his insight on principles of regenerative medicine.
Bismillahirrahmanirrahim and Assalamu alaikum. Thank you very much for inviting me to discuss about the principles of regenerative medicine. Though it is a very wider topic and I will try to be concise and relevant to your specialty. This is my introduction. I think Dr. Irfan has already had a very generous introduction, so I will leave this side. First of all, the definition of the regenerative medicine. Regenerative medicine is the process of creating living functional tissue or repair or replace tissue or organ function which are lost due to the age, disease, damage or congenital disorder. This field holds the promise of regenerating damaged tissue and organs in the body by stimulating previously irreparable organs to heal themselves. This is the definition of aging, or we can say aging basically starts from the aging is not like the aging does not start at the organism level. Aging starts from the molecules, from the genes, from the cells, and then the tissues, and then the organism. And aging is basically the imbalance when breakdown of our tissues or cells exceeds the repair. So the purpose of regenerative medicine is to shift the balance, to increase the repair and to decrease the breakdown in our body. So how regenerative medicine helps, or how regenerative medicine shifts this balance towards repair. Regenerative medicine functions by reducing pain. I will be discussing it, how it reduces pain and how it reduces inflammation. Regenerative medicine, when I say regenerative medicine, I want to say the regenerative therapeutics which are biomolecules or cells, stem cells. They reduce pain and they reduce inflammation, heal the affected, degenerative and inflamed tissue, stop or slow the progress of the degeneration and provide regeneration tissue to the organs. Treatment objective for the degenerative conditions. Regenerative medicine improve the ratio of cell loss versus the cell production. Improves the hostile microenvironment in the diseased tissue, which can be eye or any tissue, and it provides an anabolic state to inhibit cytokines and degrade proteoglycans. It stimulates the proteoglycans and glycoprotein glycans, and they provide necessary growth factors. All the regenerative tools, it can be PRP, stem cell, exosomes, or anything. They provide necessary growth factors to produce ECM, extracellular matrix, and they provide repair and regeneration of the diseased cells. And in this way, they bring the tissue, our tissue, to the cellular equilibrium. This is just to highlight that how regenerative medicine is very hot topic for the research. there is a dramatic increase in the regenerative medicine references over 14,254 are total references in PubMed during 2021. This is a huge reference. Means people are working on it very heavily, and there are 248 systemic reviews and meta-analysis. And if we search the regenerative medicine on the PubMed, you can see the trend here on the graph. If you can, here in 1920 there was no clue of the regenerative medicine, and it is in 2020s it's going very high. It's a trendy in the clinical sciences. And if we try to search the stem cell therapy on the PubMed, then you can see from 1958 what is the trend. In 2020, it is going very sharply. People are working on it. So now I will come to the regenerative options available in the market here in Pakistan and in the whole world. There are two types of the regenerative therapies. One is the cellular, in which we use the whole stem cells to treat a degenerative tissue. And the second modality of the treatment is acellular molecules, which are regenerative molecules. The cellular therapies are again two types. Either they are autologous stem cells or they are allogenic stem cells. Autologous stem cell therapy includes very famous therapy PRP, and it includes autologous SVF. SVF stands for the somatic vascular fraction. I will be explaining it in the next slides. Somatic vascular fraction is basically we get from the adipose tissue, from the lipoaspirate, and we derive the stem cells from the lipoaspirate, and these stem cells are then used to regenerate the different tissues. Then the third one is the autologous adipose-derived mesenchymal stem cells and autologous blood-derived stem cells. These are the type of stem cells therapies. And in the allogenic category, there is the umbilical cord-derived stem cells. These are the very famous stem cells, and these are being used very widely in ophthalmology and many other disciplines to regenerate the tissue disorders. And if we talk about the acellular therapies, which are of the regenerative medicine, these include exosomes, and these include adipose-derived stem cell secretome, and they include umbilical cord stem cells, derived exosomes, secretome, and amniotic fluid. These are acellular options for the regenerative medicine. So now I will discuss one by one very briefly how PRP, SVF, stem cells, and acellular components function to regenerate the tissues. First one is the very famous one, platelet plasma. People are using it very extensively. It's again FDA approved. But the only thing which is very compulsory to know is we have to prepare all these regenerative tools, whether they are cells or whether they are acellular products, in a proper laboratory. When we say a proper laboratory, it should be CGMP qualified. And CGMP qualified is an international standard of the laboratory. It starts from the designing of the lab to maintenance of the lab and functionality of this lab, reporting of this lab. But again, this is not our topic of discussion today. But please bear in mind, whenever we talk about the application of the regenerative medicine to any clinical site, we have to prepare all the biomolecules in a laboratory which is CGMP qualified. CGMP qualified, I will be discussing in the later slides. PRP is a blood plasma that has been enriched with the platelets, and we prepare the PRP by centrifuging the whole blood, and routinely we do a single step preparation of the PRP or double step preparation of the PRP. So we basically centrifuge and we get this sort of a PRP after centrifugation. Upper part, as you all know, is the plasma. It contains many growth factors. The lighter molecules are on the upper side, alpha microglobulins, growth factors. There are so many growth factors which are present because they are lighter and they are on the upper side. Sorry. I'm sorry. Yeah. And if you see, here is the Buffy coat where our white blood cells and some of the blood-derived stem cells are present in the Buffy coat region. And here the most heaviest part cells, red blood cells are present. So we normally use this part of the PRP for different applications. Again, PRP is of two types. I'm not going into the details of it. Either it is leukocyte-rich PRP or it is leukocyte-poor PRP. For ophthalmology, it is recommended to use leukocyte-poor PRP because leukocyte-rich PRP somehow induce inflammation, although they have stem cells, but still they have many molecules which can induce the leukocyte itself can induce the inflammation and that can cause damage to the eyes. So these are different growth factors which is present in the PRP. I think I will leave these. There are so many growth factors and each of them have a different function in the regeneration. I will be discussing in the next slide. Now the question is how PRP regenerates eyes or any damaged organ. It regenerates the tissues, damaged tissues by 5 different mechanisms. First one is the neuroprotection growth factors. There are neuroprotective growth factors such as nerve growth factor, brain-derived neurotrophic growth factors, IGF-1, insulin-like growth factor 1. These has shown protective effects on the photoreceptors in clinical models. These growth factors may delay the degeneration of the remaining photoreceptors in the RP patient. And the second mechanism by which PRP helps to regenerate the damaged tissue is the anti-inflammatory and antioxidant actions. There are certain anti-inflammatory cytokines, for example, interleukin-4 and interleukin-10 is present in the PRP, and in the very same way, alpha microglobulin 2 is present, which is again an anti-inflammatory molecule. So they have it can counteract oxidative stress by enhancing the local antioxidant capacity. There are certain molecules in the PRP which induces the oxidant pathway, production of the antioxidants in our own body. So antioxidants are produced and they create a friendly environment to regenerate the tissue. And the third mechanism by which the molecules present in the PRP can help regeneration is the angiogenesis and improved blood vessel supply, which is through these two growth factors, main two growth factors, VEGF and PDGF, which is present again in the PRP. And the fourth mechanism by which PRP stimulates or helps to regenerate the tissue is the stimulation of retinal pigment epithelium repair. RPE cells plays a crucial role in photoreceptor survival, their regeneration, and can directly benefit photoreceptors in the RP. And the fifth mechanism is the tissue healing and support matrix. PRP supports extracellular matrix remodeling, which may improve the microenvironment around the degenerating retinal cells. This is one of the articles. There are many studies. It's our one case report in which we reported a 27 years male with a phalanx, little finger fractured, and the patient reported to the hospital with a dry gangrene and very painful gangrene. And the patient had a couple of PRP and photobiomodulation sessions, and after 4 weeks, the patient, this was the initial when the first PRP was injected, and this is the second picture, and this is the picture after treatment before the mobility, and this is the stage when the fingers have the mobility as well. This is one of the case studies with the PRP. And the second segment, as I mentioned in my slide, is the stem cells itself. There are autologous and allogenic stem cells which are being used for the regenerative purpose. And Stem cells are basically undifferentiated biological cells that can differentiate into any specialized cells and can divide through mitosis to produce more stem cells and to produce more specialized cells. They are found in multicellular organisms. So stem cell have two properties. One is they can renew oneself. One stem cell can produce one more stem cell by mitosis, and they can produce the mature, the required stem cells in the microenvironment, and they divide by the mitosis. Types of the stem cells I already mentioned, and this is the example of the clean room. I'm not going into the details of the clean room or the structure of the laboratory because it's again a big topic to discuss. So this is just quick example how the clean room looks. This is only the clean room, and there are many other requirements. There are 3 buffer zones to enter into this clean room and 3 exit zones to exit this clean room. Clean room has require many things. It requires from floor to roof. There should be nothing porous inside the clean room because the porous, if the surface is porous, it will carry the bacteria and it does the contamination of our final products. This is the routine PPE which we use in our regenerative medicine lab. This is sanitization protocols. This is the air quality monitoring. We regularly, each week or second week, we do the air quality monitoring of the laboratory in order to see if there are any microbial load in the laboratory. And this is the slide which I would like to elaborate a bit. This is a slide which is showing how we produce the stem cells in the laboratory. First one is the amniotic fluid. Amniotic fluid directly comes in the syringes into the laboratory, and we have a first spin of 2000 rpm for the 20 minutes, and after the centrifugation we get the sorry we filter this supernatant with the zero point 0.4 micron filter. When we say 0.4 micron, it means it will not allow to pass any bacteria, any cells through it. It will be only a acellular product. It will include all the acellular component. It can include exosomes, it can include growth factors and all that. And then we second centrifuge, and then we pass through 0.2 micron filter, and then we get the final product. Okay, and the second one is how we culture the umbilical cord stem cells in the laboratory. We get the umbilical cord after ethical consent from the patients, and we cut the umbilical cord into 2 to 3 centimeter pieces of the umbilical cord, very small, tiny pieces. Then we grow these umbilical cord pieces by 2 methods. One is the explant. In the explant method, we directly place these pieces into the tissue culture plate, and then we supply the media into it, and after certain days, 2 to 3 weeks after inoculation, the stem cells start coming out of this tissue, and then we start culturing these stem cells for the application. And the second method is the collagenase method. Collagenase method means we digest the tissue with the collagenase, and it facilitates to escape the cells from the tissue quite early. And third one is the adipose. And in the adipose stem cell, the starting material is the lipoisoprate. Any patient who wants to have the stem cell therapy, we get the lipoaspirate of that patient. We wash this lipoaspirate, and there is a particular method by which we separate the stem cells from this lipoaspirate. And once the stem cells are isolated, then we culture it to the lab, and we prepare the stem cells. Okay, here I am using 2 terms. One is the stem cell, and second one is the stem cell derived conditioned media or the secretome. Stem cells which are present on the surface of the plate, and the liquid which is present on the cells, that is called secretome. The liquid part is the secretome. In the secretome, stem cells secrete many growth factors. They secrete growth hormones, growth factors. They secrete exosomes, which is very trendy these days. Exosomes are secreted by the stem cell into the supernatant. And then we use this supernatant, which we call the secretome, for different regenerative purposes. This is one of our patent, which we latest patent, not latest, in 2024, we patented one novel formulation for the treatment of ophthalmic ulcers. And the patent application number is this one. This is under in progress, and we are ready to go through the register the clinical trial for this formulation. What is in this formulation? Basically, in this formulation, we have okay, okay, sorry. So in this formulation, I will stop, I think, on this slide, a couple of slides more. In this formulation, we have four things. This is basically for ophthalmic ulcer, and it is very good alternative to the PRP, which some of the doctors suggest for the ophthalmic ulcers. What we use basically in this formulation is polyethylene glycol base, and we use amniotic fluid in a proper portion. It is sorry, I'm sorry. And then we use adipose stem cell derived condition media, yes, secretome, and we use umbilical cord stem cell derived condition media or secretome, 5% of the adipose derived stem cells, 5% of the amniotic fluid, and 5% of the umbilical cord derived stem cells secretome. This is the recipe of this formulation, and it has very marvelous results because I'm not a clinician. Clinicians are using, I think Dr. Irfan can better explain. There are many patients who use it and they have very good results. If the time is over, I think I will stop it here. No worries. Means there are many more slides. If you want, I can talk for 5 minutes more. Okay. This is about the quality control of the adipose derived stem cells and the umbilical cord derived stem cells. I think it should not be discussed there. It's very tricky and a laboratory thing. You will not able to get it even. So I will skip these slides. This is basically how these stem cells, we confirm these are the stem cells or not the other cells. We normally use PECs. I think you have heard about it. Anyway, this is just quick quality control. If there is any bacteria in our final product, we do the culture. So the culture must be negative for any regenerative product. And this is the test finally we do for any regenerative, whether it is stem cell, whether it is exosome, we do HCV, HBV, HIV, and syphilis test to make sure there is no HCV, HBV, and syphilis contamination into the final product. So these are the stem cells which are derived from the blood. This is the procedure. Again, shortage of time, I am making concise. So this is the part of procedure. To get the blood derived stem cells, we inject GM-CSF, filgrastim, into the patient for 4 consecutive days to increase the number of CD34 plus cells. And then on the day 6, you can see here the trend. On the day 6 or the day 5, you can get maximum CD4 positive cells. We perform the procedure, and this is the procedure. Means blood is collected directly from the patient and it is processed in the machine, and blood derived stem cells are collected and then they are injected for any clinical indication which are required clinical indications. So this is the machine, I am leaving it. How MSCs help regeneration? This is almost the same methods by which PRP regenerates the tissue. There are 6 methods. There are 6 methods by which the stem cells regenerate. They are almost the same like PRP. So I am again leaving these. This is one of our study, that is the management of type 2 diabetes mellitus using adult autologous adipose derived stem cells along with PRP. This is a reported study, and this is the secretome. Already I discussed a bit what is secretome. Secretome is basically supernatant present on the top of the stem cells, which contain growth factors, exosome, and all that stuff. So exosomes are very good alternative to the stem cells therapy due to many reasons. Because stem cell therapeutics have low survival and engraftment rates, and they are prone to the mutagenesis and the carcinogenesis. Sometimes they become immunogenic, and again, there is a mechanism, pulmonary first pass effect, in which our stem cells are first trapped in the lungs. When we inject in the patients, they are first trapped in the lungs. So due to these problems, acellular products are better to use. Exosomes are very effective. Growth factors are very effective. So secretome or secretome can, that particularly exosome, they are very good tool to regenerate the tissues. Exosomes and the secretome have very good evolving applications in the ophthalmology and all other medical disciplines. I would just like regenerative medicine has a very good potential, clinical potential. You can make an idea from the market value of the regenerative medicine. The current regenerative medicine market is around 40 to 50 billion dollars. It's almost the budget of Pakistan. Only the regenerative medicine exceeds 40 to 50 billion dollars per year. And if you compare any other clinical discipline, for example, if we talk the microbiology only, it has 1.28 billion dollars budget only, market value. So it has a very high market value and it has a very high potential, clinical potential. This is one of our study in which we use the secretome for the wound healing. Thank you very much. I will stop my talk here. Thank you very much. If you have any question. Yeah. 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 Mhm. For the dry eyes, yeah. Actually,
There are studies, we not get very intravitreal is not safe for yeah. It's a key that give rise to a very expensive uncontrolled fibrosis and cellular toxicity, which can subtract can be which can further give rise to better entanglement, PGR, and submacular fibrotic membranes. So, intravitreal route is not a very safe for this. The clone is the most safest food so far. It has almost zero competition.
and for the dry eyes, I think the drops.
Yes, drops are very effective as well as the dryness or dryness. Yes, that is another reason. Thank you, Dr. I'm really grateful that you have space and time.
Sorry. 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 इसको निकाल.
Thank you very much, Dr. Jain, for your comprehensive talk, covering all aspects of regenerative medicine. These types of regenerative medicine communication
यही बातें चाहे प्रोफेसर दी की बात हो, रजाई का हो, ब्रिलियंट भी का हो, दी आसिफ साहब को रास्ते चले हैं, वो सारे में ऐसा रास्ते ही कहते आए हैं। आपकी जो प्रेपरेटरी कोर्स है, ये एंड करवाने के बजाय आप उसको शुरू में लीजिए। दिस इज असेसमेंट फॉर द लर्निंग, फॉर्मेटिव असेसमेंट। तो जब ये असेसमेंट कराने के बाद शुरू हुई, तो सीपीएस के प्लेटफॉर्म से हमारे जो बहुत सारे जो लर्निंग टीचर्स हैं, जिसमें मजीद जाने वाले प्रोफेसर हमको वर्ड का फिर बात शुरू हुई है असेसमेंट की। उसमें एवरेज के फ्यू मिनट्स इसमें 1 मिनट नाम है इसमें से ईएमयू और फिर इसमें 2 मिनट का फीडबैक होगा सर काम पर फीडबैक। इसमें जो बीडीसीएस बीडीसीएस टोटल होंगे 4 पहले 2 साल में अच्छी होने वाली थी। और इसमें जो बीडीसीएस अगर बात करें तो ये 20 परसेंट है जो आपने कवर कर दी। अगर आप ग्राफ की बात करें, ये रिक्वायरमेंट ग्राफ्स डायरेक्टली अगर ये टोटल 12 है। ठीक है, हर 4 महीने बाद यहाँ का की और इसमें जो लीस्ट का है ये रहे। और अगर हम बात करें सर्टिफिकेट के लिए जो कैबिनेट सर्टिफिकेट ऑफ एक्सपीरियंस असेसमेंट रूब्रिक्स ऑस्कर उसमें जो 2 आप एक्स्ट्रा करते हैं पहले 2 साल में, फिर 3 नए पेपर्स देते हैं। इसमें बताना चाहूंगा कि हमने टीचर्स मोटिवेट करना रहते हैं। आपने अपने पोर्टल में कैसे कर सकते हैं कि मैं गुरु के यहाँ लर्निंग फीडबैक आपको पढ़ सकता
So, as a student, Nasir has shared with you, the workplace assessment is an initiative taken by the PSC to check the competency of residents in real-time clinical basis. So, we have heard the tools that have been shared by Dr. Nasir. As we are surrounded by different supervisors right now, this tool, this assessment is going to be carried out by the supervisor for their particular residents. So, the resident is going to prepare in their particular field. Jobs, it could be OCS, it could be the Oscars or the extra or take and once they prepare, they will contact the supervisor, they will let them know if they are prepared for it, and then the supervisor will arrange for that particular session. And these sessions will last for 15 minutes. For 15 minutes, the supervisor will assess the performance of the resident, and then for 5 minutes are for the feedback. Now, the performance evaluation by the supervisors and that performance, the access of that will be provided on the portal. So, I'll share with you. So, this is how you will log into your CPSC portal for the professors and supervisors here. Just how you log into your portal. And then you will type for the
sitting here. तो अभी रिजल्ट में जहाँ हूँ, डॉक्टर आमना से मैंने इतना कुछ सीखा है। वो मुझे एक स्लाइड आपने जो दिखाई थी विच वाज वन चार्ट, वो दिखा सकती हैं? देखिए, हम सारी उम्र इम्तिहान तो देते रहे हैं और इम्तिहान की सबसे बड़ी कबाहत ये होती है कि उसमें बंदा पास हो जाता है और फेल हो जाता है, एक कोई ना कोई नतीजा जरूर निकलता है उसका। बट दिस इज समथिंग जहाँ पे हम पास फेल पे तवज्जो नहीं दे रहे, हम सिर्फ एक असेसमेंट की एनवायरनमेंट दे रहे हैं और उसमें अगर वो उसमें कोई कमी बेशी है तो फिर वो उसमें इम्प्रूव कर सकता है, रिपीट भी कर सकता है। When we were designing this, it looked like an impossible job. फिर इसको इतना सादा बनाना था कि वो बाइट साइज डाइजेस्टेबल हो, सब लोग कर सके। सबसे इम्पोर्टेंट चीज ये है, आपने कोई पीएचडी लेवल की चीज नहीं बना देनी जो कि बिकम सो हैवी कि आप उसे इस्तेमाल ना कर सके। तो इट हैज टू बी यूजर फ्रेंडली। और जो तीसरी चीज थी वो ये थी कि आईटी solutions, digitization has made it possible. फर्ज करें सारे परफॉर्मा आपके पेपर बेस्ड होते हैं और आपने उनको भरना है और फिर फाइल, जिस तरह हमारी एक ई लॉग होती थी, आप उनको भर रहे हैं फिर उसको सबमिट कर रहे हैं। So this is real time IT के ऊपर। So the workflow was actually 4 steps. There was the faculty, the residents CPSP में, they should know there are structures. There is the faculty of ophthalmology, of which I was the dean previously, और उस faculty of ophthalmology की आगे working committee थी WPA की, and I'm very grateful to General Mazhar, who is the counselor of the college, Professor Moeen, who is not sitting here. We actually had a consultative meeting with Carl Bolnick, who has been coming to OSP for the last 4 or 5 years now. तो कहने का मतलब है दिस इज ए collaborative effort in collegiality perspective. एक बंदे के काम नहीं है, मिलके बैठ के काम, टीम वर्क का काम है। तो after this chart was designed, when we were discussing it, तो हमने सिर्फ ना, आप OCX को समझे कि शॉर्ट केस है, आपने एक शॉर्ट केस में हिस्ट्री लेनी है, एग्जामिनेशन करना है, रेलेवेंट इन्वेस्टिगेशंस करनी है और ट्रीटमेंट प्लान देना है। तो आइडिया ये था कि आपको शॉर्ट केस को एग्जामिन करने का और समवेयर थोड़ा सा एक्सटेंड करें तो लॉन्ग केस, एक फ्लेवर दें ट्रेनी को एक स्ट्रक्चर्ड परफॉर्मा के ऊपर। तो वो परफॉर्मा इंटरनेशनल काउंसिल ऑफ ऑप्थेल्मोलॉजी का अप्रूव्ड परफॉर्मा है। यू डोंट हैव टू रीइन्वेंट थिंग्स, चीजें बनी हुई हैं, सिर्फ आपने उनकी सेटिंग ऐसे करनी है कि हम सब इस्तेमाल कर सकें और सब उसको ओन कर सकें। So the 4 OCX encounters, और फिर कार्ल बोलने हमें कहा कि इसको शॉर्ट केस अगर आपने पहले 2 साल में दिखा दिए हैं तो तीसरे चौथे साल में दोबारा दिखाने की क्या जरूरत है, टाइम भी वेस्ट करेंगे ट्रेनिंग का भी और इसको बार बार करना भी मुश्किल है। तो हमने 4 ब्रॉड एरियाज डिजाइन किए दी फर्स्ट 2 years, और फिर डॉग्स के हमने इनिशियली 8 बनाए, लेकिन फिर मैंने इसमें बायोमेट्री ऐड की और फिर I thought very strongly, I'm very thankful to Khaja Khalid Shoaib, who is sitting here, is the secretary of the faculty, और I'm very thankful to him, जो उन चीजें डिजाइन करते थे, ये मैं नहीं, उनकी ओनरशिप लेते थे और उनको फैकल्टी से अप्रूव करवाते थे। तो रेटिनोस्कोपी विद स्पेक्टिकल प्रिस्क्रिप्शन राइटिंग आई थॉट इज वेरी इंपॉर्टेंट, ये जरूर डालनी है। तो वो हमने डाली कि आपने एक ऐनक का नंबर चेक कैसे करना है, सेकंड ईयर में आपको आना तो चाहिए ना एक दफा। और फिर हमने इसके अंदर गोनियोस्कोपी को भी ऐड किया। तो छोटे छोटे प्रोसीजर्स हैं, ऑफिस बेस्ड हैं, जो आप रूटीन में वार्ड में करते हैं, माइनर थिएटर में करते हैं। आपने सिर्फ एक स्ट्रक्चर्ड तरीके से वो करके अपने ट्रेनर से उस पर फीडबैक लेना है, आपने उसकी पहले तैयारी करनी है, फिर आप प्रेजेंट करें, आपके पास पूरी, दिस इज द होल थिंग व्हिच इज टू बी डन इन 4 years। तो हमने इसको बहुत थोड़ा छोटा डूएबल करके रखा है। और फिर ये मेरे एक ट्रेनी है हैदराबाद में, जब हमने इनिशियल पायलट किया इसको, तो उन्होंने कहा कि आपने फेको को फर्स्ट ईयर में रख दिया, तो फर्स्ट ईयर से तो फेको कोई फर्स्ट ईयर ट्रेनी को हाथ लगाने की इजाजत नहीं देता फेको को। सो शी सजेस्टेड दैट आप एक्स्ट्रा कैप्सुलर को एंटर करें इसके अंदर। तो वी हैव आपको सेकेंड ईयर के एंड पे एक्स्ट्रा कैप्सुलर असेस करके सर्टिफाई करवाना है और अपने सेकेंड ईयर में पेपर शुरू करना है। और जब आप इसकी अभी डिटेल्स में जाके इनके परफॉर्मेंस को देखेंगे तो अपने फर्स्ट सेकेंड ईयर में सिर्फ चिजल करना है आपने, थर्ड ईयर में क्रैक करना है न्यूक्लियस को और फोर्थ ईयर में पूरा प्रोसीजर करना है। तो मैं उसकी डिटेल्स में नहीं जाना चाहता इस वक्त। what we are trying to do is कि एक छोटे छोटे स्नैपशॉट शॉट्स के अंदर ट्रेनी की एक पिक्चर बनाएं कि वो 4 ईयर में इतना ट्रेन हो जाए कि वो अपनी सारी टीम के साथ इंटरैक्ट करे। अच्छा, इसमें प्रोफेसर साहब का होना कोई जरूरी नहीं है, प्रोफेसर इज पार्ट ऑफ द टीम लीडर, लेकिन आप अपने सीनियर रजिस्ट्रार, असिस्टेंट प्रोफेसर, एसोसिएट प्रोफेसर किसी से भी वो एनकाउंटर करके सर्टिफाई करवा सकते हैं, उसको साइन ऑफ से सुपरवाइजर करेगा। तो पहले अभी इतना ही रखते हैं, इसको ज्यादा स्कॉलरली नहीं बनाते, बट आई एम वेरी हैप्पी दैट द ट्रेनीज हैव टेकन इट अप। तो असल जो स्टार ऑफ द शो है वो तो ट्रेनी है। तो अगर ट्रेनी को समझ आ गई है ना तो हमें अपना रिवॉर्ड मिल गया। दैट्स द वे आई लुक एट इट। थैंक यू। अच्छा, जाते जाते एक और चीज, क्योंकि बहुत सारे, एक चीज जो मैं आपको जाते हुए जरूर नासिर साहब के दोस्तों से कहना चाहूंगा, सीपीएसपी और ओएसपी बहुत पावरफुल प्रोफेशनल बॉडीज हैं और ये जो वर्क बेस्ड असेसमेंट को टूल डेवलप हुआ थ्रू कोलैबोरेशन विद ओएसपी एंड सीपीएसपी। और एक और चीज जो मैं मेंशन हमेशा करता हूँ वो यू अपकमिंग जनरेशन लर्न टू पब्लिश, लिखें, पब्लिश करें। और आज के इसमें जितने लोगों ने अभी प्रेजेंट किया है, 3-4 लोगों ने, दे हैव डन अ मार्वलस जॉब। आपकी पावर पॉइंट की स्लाइड्स तैयार हैं, केस बिल्कुल तैयार है, सिर्फ आपने इसको केस रिपोर्ट में कन्वर्ट करके पीजीओ में पब्लिश करना। दैट इज द मैसेज एंड दैट विल मेक अ ह्यूज चेंज। आपने जबरदस्त प्रेजेंटेशन की हैं, इंटरनेशनल लेवल की, मैं तो कहूंगा सिर्फ आपने इसको पब्लिश करना है और इसको सिर्फ बेशक चैट जीपीटी और डीप सीक और व्हाटएवर हेल्प जिसकी थोड़ी थोड़ी इजाजत है उसके थ्रू जाके अपनी पावर पॉइंट प्रेजेंटेशन को टेक्स्ट में कन्वर्ट करें और उसको पीजीओ प्रोफेसर तैयबा बोले आप एडिटर इन चीफ, उनको भेज दें और अपने लिए छोटे छोटे गोल सेट करें। आपने 1 महीने के अंदर अंदर जितनी ये 4 पॉइंट प्रेजेंटेशंस हैं, you must publish them as case reports in PGO. That is my message.
We all are aware of the fact that Jinnah hospital is under civil currently. So it was a gigantic task to hold our clinical meeting. I think this would be a great amount of for the entire faculty,
लाइट्स ऑन कर दे, लाइट्स ऑन करा The position going to announce बहुत थोड़ा सा फर्क था सामने बहुत अच्छी presentation थी. The first position goes to Dr. Sara Farooq for departmental report. Please welcome our doctor. Very good presentation, Dr. Sara. Second prize for Dr. Chater Abbas for a very good presentation. And for third position, Dr. Samar Saeed for steroid responder uveitis. Dr. Salman Nasir, please come on the stage and take your certificate. Your presentation was also very good, Mashallah. बस एक एक मार्क से पोजीशन ऊपर नीचे आई है, सबकी बहुत अच्छी थी. Professor Dr. Zainab Abbas, please come on the stage.